Picture this scenario. It is 5 p.m. on a Friday. The pharmacy is absolutely slammed, right?
Oh, the classic Friday afternoon rush, the worst.
Yeah, exactly. The phone is ringing, there is a line at the counter, and you are just reviewing a stack of prescriptions.
Right.
You pull the next one from the queue, and it's for a newly diagnosed rheumatoid arthritis patient. And the drug is methotrexate, commonly known here in Australia as methylblastin.
Okay, yeah, that's standard.
But you scan down to the directions, and your stomach just drops. The SIG literally says, take 1 tablet by mouth daily.
Oh, wow. Yeah, that's a clinical catastrophe right there.
It really is.
Because the danger in that moment isn't just like a severe side effect. It's a complete life-threatening shutdown of the bone marrow.
Exactly.
A single word, daily instead of weekly, turns a cornerstone therapy into a profound myelosuppressive event.
It's a moment that demands a complete halt in your workflow. So, welcome to this deep dive. As an early career pharmacist, whether you are driving home from the community pharmacy or, finishing up ward rounds, you definitely know this specific nightmare.
Yeah, we've all been there.
This is part of Therapeutics Drive by PharmaAnywhere, designed specifically for Australian practice. Today, we are taking a massive stack of clinical sources, ranging from current immunology data to the ETG, the therapeutic guidelines on rheumatoid arthritis management, and we're distilling them down.
Right, because our mission is to equip you with high-yield, practical clinical pearls, stuff you can use the moment you step back up to the checking counter.
Exactly. We are bypassing the basic anatomy to look directly at the granular immunology and the latest treatment algorithms.
Yeah, the goal is to unpack why errors like that daily methotrexate script actually happen, how to intercept them, and critically, how to confidently counsel a newly diagnosed, highly anxious RA patient who is standing right in front of you.
Because when a patient gets that RA diagnosis, they are usually in a lot of pain.
Oh, absolutely. And they're terrified.
Right, terrified of what it means for their mobility, their future. But before you can intercept an error or counsel them effectively, you really have to understand the invisible fire happening inside their joint spaces.
Yes, systemic inflammation is the absolute core of this. We are dealing with an aggressive immune response, which is, quite distinct from the mechanical degradation you see in osteoarthritis.
Right, it's not just wear and tear.
Exactly. This is a targeted, sustained autoimmune attack.
So let's bypass the basics and look at how this friendly fire actually operates. We know the synovium develops a panosis.
Yes.
And this isn't just normal swelling. This is a highly vascularized invasive tissue. It's essentially building a siege engine right inside the joint space.
That's a great way to put it. Driven by a CD28-mediated T-cell cascade.
Right. So exactly how do those chemical messengers, the pro-inflammatory heavy hitters like TNF-alpha and interleukin-6, how do they execute the destruction?
Well, they disrupt the fundamental equilibrium of bone remodeling.
Okay, how so?
So IL-6 and TNF-alpha aggressively upregulate osteoclastogenesis. They're telling the body to break down bone.
While suppressing the osteoblasts that build it back up, right?
You got it. While actively suppressing osteoblast function. So you get this rapid simultaneous destruction of both the cartilage and the underlying subchondral bone.
Wow.
And at the same time, TNF-alpha is stimulating fibroblasts and chondrocytes to release matrix metalloproteinases.
Which just chew through everything else.
Yeah, they systematically degrade the connective tissue. It's complete dismantling of the joint.
So when that patient walks up to your pharmacy counter, they often just assume they have standard wear and tear joint pain, like, oh, my hands are getting old.
Right, very common.
But differentiating this systemic fire from osteoarthritis is crucial when you are taking a medication history. RA typically presents symmetrically, right? Usually starting in the small joints, the MCP and PIP joints of the hands and feet.
Yeah, and the morning stiffness duration is your massive diagnostic clue during that history taking.
Because OA stiffness is pretty quick to resolve, right?
It's exactly. Osteoarthritis stiffness generally resolves in under 30 minutes once the patient gets moving.
Okay.
But in RA, that stiffness is debilitating. It lasts 60 minutes or longer. And because the inflammation is systemic, you will often see fatigue, weakness, or even a low-grade fever accompanying the joint pain.
What I find staggering, honestly, is the timeline of this pathogenesis.
Oh, it's wild.
The B lymphocytes start producing specific antibodies, specifically rheumatoid factor and anti-citrullinated protein antibodies, or ACPA, long before the patient feels any of that stiffness.
Decades in some cases.
Decades. Wait, really?
Yeah, absolutely. Those autoantibodies aren't just diagnostic markers.
Hmm.
They're pathogenic drivers, and they act as prognostic red flags.
So they tell us how bad it's going to get.
Right. The presence of high-titer ACPA, even if their rheumatoid factor is negative, strongly predicts a highly aggressive disease course with a rapid radiographic progression.
Wow.
The immune system is actively neutralizing self-antigens literally years prior to the clinical symptoms showing up.
Which fundamentally dictates our clinical strategy, right? Rapid, aggressive intervention.
Has to be.
If we know that irreversible structural damage accumulates the longer the fire burns, delaying treatment is just unacceptable.
Yeah, the ETG standard of care is to initiate a conventional synthetic disease-modifying anti-rheumatic drug, a CSD-MARD, immediately upon diagnosis.
You don't just wait and see with some Nurofen.
No, not at all. Treat to target. The target is clinical remission or, at a very minimum, low disease activity.
Right.
The algorithm simply does not allow for a wait-and-see approach with NSAIDs alone. You must get a DMARD on board to alter that disease trajectory.
But here is the real clinical friction for you at the counter. You dispense that methotrexate, but you know the patient won't feel its effects for another 4 to 8 weeks.
Yeah, that lag time is tough.
We have a massive therapeutic gap. The patient is in agony right now. So how do prescribers manage the timeline between initiating the DMARD and the patient actually achieving systemic relief?
Well, prescribers rely heavily on bridge therapy.
Okay, bridge therapy.
Yeah, to suppress the acute inflammation during that latency period, a short-term course of low-dose glucocorticoids, like prednisone, often seen under the brand name Panacort here, is initiated alongside the DMARD.
Okay, let me push back on how we handle this in the real world, because this is a scenario every community pharmacist battles, I swear.
Oh, I know where you're going with this.
A newly diagnosed patient starts their methotrexate and their Panacort bridge. The steroids make them feel incredible.
Oh, Matty pill.
The inflammation plummets, the fatigue vanishes, they feel like they have their life back. How do you stop that patient from relying solely on the steroid high and just, abandoning their slower acting DMARD?
Yeah, it's a huge issue. It requires a very deliberate counseling strategy that validates their immediate relief while setting strict boundaries.
Right.
I highly recommend using the scaffolding analogy.
Ooh, I like that. How does that work?
You explain to the patient that the prednisone is just temporary scaffolding. It holds the building up and makes everything look stable while the real work is happening underneath.
And the methotrexate is the actual foundation repair.
Exactly. The scaffolding is essential, but it's not the building.
That analogy is brilliant because scaffolding is inherently temporary. You literally can't leave it up forever.
Right. And the ETG recommends limiting glucocorticoid bridge therapy to 3 months or less. Taking more than 2.5 milligrams per day of prednisone long-term is just a physiological disaster.
Because the RA itself is already chewing through their bone density via that osteoclast upregulation we talked about earlier.
Precise.
Add long-term corticosteroids, which suppress intestinal calcium absorption and directly inhibit osteoblast formation, and you're basically guaranteeing profound osteoporosis.
Yeah, not to mention the suppression of the HPA axis, increased susceptibility to opportunistic infections, accelerated atherosclerosis, hyperglycemia.
The list goes on.
It really does. You have to look the patient in the eye and assure them that while the DMARD is frustratingly slow, it is the only vehicle for safe, long-term disease modification.
So let's focus on that foundation repair. The anchor of RA therapy across almost all guidelines is methotrexate.
Yeah, it is the preferred initial therapy due to its proven efficacy, its cost-effectiveness, and honestly, a very manageable safety profile when monitored properly.
Right.
Methotrexate exerts its primary anti-inflammatory effect by inhibiting dihydrofolate reductase, DHFR.
Which brings us right back to that Friday afternoon nightmare script. The mechanism explains the danger.
Exactly.
By inhibiting DHFR, methotrexate deprives rapidly dividing cells of the folates they need to synthesize purines and pyrimidines for DNA replication.
It essentially starves the hyperactive immune cells, halting the clonal expansion of T cells and B cells that are driving that PANAs in the joint.
Right, but if you dose it daily instead of weekly, you starve every rapidly dividing cell in the entire body.
Yeah. The bone marrow stops producing leukocytes, erythrocytes, and platelets. The intestinal mucosa breaks down. It is a fatal error.
So whenever you see a methoblastin script, you should treat it like a giant flashing stop sign. It is a moment to physically halt, check the frequency on the label, verify the indication, and actively counsel the patient.
And because we are deliberately inducing a folate deficiency to calm the immune system, We have to rescue the healthy cells.
Right, which is why we see folic acid supplementation universally prescribed alongside it.
Yeah. Concomitant folic acid, typically given daily except on the day of the methotrexate dose, significantly reduces the incidence of folate-depleting toxicities.
What toxicities are we specifically trying to avoid there?
We're mostly trying to prevent stomatitis, those incredibly painful oral ulcers, as well as nausea, alopecia, and mild cytopenias. We can do that without compromising the efficacy of the DMARD.
Now let's look at the patient demographic for a second. RA has a heavy female-to-male prevalence, right?
Yes, significantly higher in women.
Which brings up a critical counseling requirement for early career pharmacists regarding family planning.
Oh, this is vital. Many agents used in rheumatology are known potent teratogens. Methotrexate use is directly associated with spontaneous abortion, severe fetal myelosuppression, and multiple congenital anomalies.
So if a woman of childbearing potential hands you a script for a CSDR, you cannot just hand over the bag and ask if they have any questions. You really have to initiate the conversation.
You must verify they're using highly effective, reliable contraception. And if the patient expresses a desire to conceive, the timeline is rigid.
How rigid?
Methotrexate must be completely discontinued for a minimum of 3 months prior to attempting conception, just to ensure full cellular clearance.
And it's not just methotrexate either. Leflunomide, another conventional DMARD often seen under the brand name Arava, has an even more complex pharmacokinetic profile when it comes to teratogenicity.
Oh, leflunomide is fascinating. It's a pyrimidine synthesis inhibitor? Sure. But its active metabolite undergoes extensive enterohepatic recycling.
Right, the liver-gut loop.
Exactly. The drug is excreted in the bile, reabsorbed in the intestines, and pushed right back into the bloodstream. Because of this loop, the half-life is extraordinarily long.
Meaning, if a patient on Arava experiences severe hepatic toxicity or needs to rapidly clear the drug to become pregnant, they can't just stop taking the tablet and wait.
No, it would take months, if not years, to reach a safe plasma concentration.
No, what do we do?
You have to intervene with a targeted washout procedure. You administer cholestyramine, a bile acid sequestrant, for 11 days.
Wow, 11 days.
Yeah. The cholestyramine binds to the active metabolite, the gut lumen, interrupting that enterohepatic recycling loop and forces the drug to be excreted in the feces.
That's amazing.
It's a brilliant pharmacological hack to rapidly drop serum levels.
Definitely a high-yield clinical intervention that pharmacists need to be ready to facilitate.
Absolutely.
Now let's shift gears. We have our foundation, usually methotrexate. The prescriber treats to target, monitoring disease activity using tools like the DAS-28 score and inflammatory markers.
Yep.
But what happens when the patient fails monotherapy? What happens when you've optimized the CSD-MARD, but the joint destruction just continues?
Well, the clinical algorithm escalates to biologic DMARDs, or BDMARDs.
This is where we see a massive leap in pharmacological targeting, and it brings a whole new layer of PBS requirements and clinical monitoring for the Australian pharmacists.
Oh, for sure. The admin side alone is heavy.
Let's look at the tumor necrosis factor inhibitors first. You'll commonly see etanercept, which is Enbrel, adalimumab, which is Humira, and infliximab, which is Remicade.
These agents are monoclonal antibodies or fusion proteins engineered to specifically bind and neutralize soluble TNF.
Okay.
So you are directly pulling the plug on the primary inflammatory cytokine driving the joint destruction.
From a practical standpoint in Australia, these are highly restricted on the PBS. Like, if a community GP writes a script for Humira, it's going to cost the patient thousands of dollars.
Oh yeah, unless it has been initiated by a rheumatologist with the correct authority code, proving they have actually failed conventional DMARDs.
Right. And the administrative hurdle reflects both the cost and the clinical risk. Because while neutralizing TNF is fantastic for the joints, it triggers profound systemic immunosuppression.
Yeah, you are deliberately turning down a major defense pathway in the body.
Which leads to a mandatory, non-negotiable clinical step before any patient can start a biologic. The latent tuberculosis screen.
Crucial step.
Every single time you see a new start for Enbrel or Humira, you should mentally flag, has the TB test been done? Why is that specific link so incredibly dangerous?
It all comes down to the architecture of a granuloma.
Okay.
When a patient is exposed to Mycobacterium tuberculosis, the immune system often can't completely eradicate it. So it builds a wall of immune cells, a granuloma, to isolate the bacteria in the lungs.
It essentially jails the bacteria.
Right. It puts the infection into a dormant, latent state.
Right.
But TNF is the essential cytokine required to maintain the structural integrity of that wall.
Ah, I see. It's like a specialized maintenance crew keeping the perimeter fence intact.
Exactly. And when you introduce a biologic that neutralizes TNF, you essentially fire the maintenance crew.
The wall collapses.
The granuloma loses its integrity, the walls literally crumble, and that dormant tuberculosis reactivates, leading to rapid disseminated infection.
That's terrifying.
It is. Screening for latent TB via a quantiferon gold test or a chest X-ray is an absolute requirement. If positive, they must complete at least 1 month of prophylactic antituberculosis therapy before you can even think about initiating the biologic.
That is a perfect example of connecting the mechanism of the drug directly to your clinical workflow.
Yeah.
Now, if we pull back and look at the broader immunosuppression, it raises a huge question about immunizations. We obviously want these patients protected against infectious diseases, but can they safely receive vaccines while their immune system is pharmacologically suppressed?
Well, you have to separate the vaccines into 2 distinct categories here.
Okay.
Administration of killed, inactivated, or recombinant vaccines is generally considered safe, though the patient's immune response might be slightly blunted. We are talking about the pneumococcal vaccines, the injected influenza vaccine, and the recombinant zoster vaccine, Shingrix.
But live attenuated vaccines are a completely different story, right?
Completely. Live attenuated vaccines are strictly contraindicated for any patient actively taking a biologic DMARD.
Why is that a hard no?
Because you have compromised their immune defenses. A live virus, even a severely weakened one like the yellow fever or the MMR vaccine, can replicate unchecked and cause an active iatrogenic infection.
So the ultimate goal is to evaluate their immunization status during the initial diagnostic workup.
Exactly.
Get them fully vaccinated, especially for shingles and pneumococcus, long before you suppress their immune system.
That's best practice, yes.
Now, we need to spend some time on a newer, rapidly growing class of medications that often gets rushed at the end of these discussions.
Ah, the targeted synthetics.
Yeah, the targeted synthetic DMARDs, specifically the Janus kinase or JA inhibitors. In pharmacy practice, you'll frequently see tafasitinib under the brand name Xeljanz or opadacitinib, which is Rinvoq.
JAK inhibitors represent a fundamental shift in how we deliver advanced therapy.
How so?
Well, biologics are large, complex proteins that must be injected or infused, right, because the gut would just digest them.
Yeah, they're fragile.
But JAK inhibitors are small molecules. They can be formulated as an oral tablet, which is a massive quality-of-life upgrade for a patient with severe hand deformities who might really struggle with injection pens.
Oh, that makes so much sense. But they work entirely differently than the TNF inhibitors, don't they? They aren't neutralizing cytokines floating around in the extracellular space.
No, they work intracellularly.
Okay.
When a cytokine binds to a receptor on the surface of an immune cell, it relies on the JAK-STAT signaling pathway to transmit that signal down into the cell's nucleus to alter gene transcription.
It's like the telegraph wire inside the cell.
Exactly. Tafasitinib and other JAK inhibitors physically block that intracellular transmission. The cytokine binds to the outside of the cell, but the cell never gets the message to trigger the inflammatory response.
It's an incredibly elegant mechanism.
Very targeted.
But it comes with a heavy clinical burden. These agents carry severe boxed warnings that every pharmacist must monitor. We are looking at increased risks of serious infections, malignancies, and uniquely, a heightened risk of venous thromboembolism and major adverse cardiovascular events.
Yeah, the cardiovascular risk is a paramount counseling point.
Rare.
Immunomodulation inherently affects lipid profiles, often raising LDL cholesterol. Furthermore, blocking these inflammatory pathways can destabilize existing atherosclerotic plaques.
Oh, wow.
So if a patient is transitioning from a biologic to a JAK inhibitor, you need to be actively looking at their cardiovascular risk factors, their age, their smoking history, and their baseline lipid panels.
Which brings us perfectly to our final overarching point of this deep dive. As pharmacists, it is so easy to get hyper-focused on the mechanics of the drugs.
Oh, absolutely. It's what we're trained to do.
Right. We focus on the weekly dosing of methylblastin, the injection site reactions of Humira, the authority codes on the script, the complex washout protocols. But we have to zoom out and look at the entire patient standing in front of us.
We really do. But before we get to that final point, let's run through a rapid recap of the core high-yield pearls we've unpacked today for your clinical practice.
Okay, let's do it. Number 1, methotrexate is a once-weekly medication.
Weekly. Always weekly.
It is the absolute anchor of RA therapy, but a daily dosing error will cause fatal myelosuppression. Always double-check the script, implement a hard stop in your dispensing workflow, and ensure concomitant folic acid is prescribed to protect the healthy cells.
Right. Number 2, Glucocorticoid bridge therapy with prednisone is vital for symptom control while we wait for the DMARDs to kick in, but it must be strictly temporary. Limit it to 3 months or less.
Because of the bone density issues.
Exactly. Prolonged steroid use drives rapid bone loss and suppresses the HPA axis. Counsel the patient that the steroid is just the scaffolding. The DMARD is the actual foundation.
Number 3, escalating to biologic DMARDs like adalimumab or etanercept requires absolute vigilance regarding immunosuppression. You must ensure mandatory latent TB screening has occurred due to the breakdown of granuloma integrity.
And you must intercept and block any administration of live attenuated vaccines.
Yes, very important.
And number 4, women of childbearing potential on conventional DMARDs like methotrexate or leflunomide arava must be counseled on severe teratogenicity. Effective contraception is mandatory, and if they wish to conceive, strict discontinuation timelines or active cholestyramine washout protocols are required.
That covers the joints, the immune cascades, and the immediate drug safety protocols. But I want to leave you with a final hidden danger mentioned across the clinical guidelines.
A provocative thought to take with you.
Exactly, something to carry with you on your next community or hospital shift. We spend all of our energy focusing on protecting the patient's joints from that internal autoimmune fire.
Naturally.
But did you know that the leading cause of mortality in RA patients is not the joint disease itself?
It's staggering when you see the data.
More than half of all deaths in RA patients are actually cardiovascular related.
Yet the systemic inflammation of rheumatoid arthritis doesn't restrict itself to the synovium. It aggressively damages the vascular endothelium everywhere.
The fire spreads to the vessels.
It does. Persistent elevation of inflammatory cytokines accelerates atherosclerosis. Current guidelines explicitly state that RA is an independent cardiovascular risk factor.
Carrying a risk equivalent to type 2 diabetes.
Exactly.
So the next time you hand over an RA medication, whether it's a weekly methylblastin dose, a Humira pen, or a bottle of Xeljanz, just ask yourself, are you also keeping an eye on their blood pressure?
Are you checking their lipid profile?
Have you asked them about their smoking status or offered cessation support? Because treating the joint inflammation is only half the battle.
It really is.
When it comes to rheumatoid arthritis, the best joint care might just be heart care.